This PowerPoint presentation on concussion return to play protocol has been developed to assist athletes, parents, coaches, and school personnel with meeting the new law requirements surrounding high school athletic concussions. We will review the definition of concussion, discuss past practices that are no longer being used to manage concussions, what the newly enacted law requires, and a sample return to play protocol developed by the state CIF Sports Medicine Advisory Committee. So what is a concussion? Well, as defined by the Centers for Disease Control, a concussion, or a type of traumatic brain injury, is caused by a bump, blow, or jolt to the head. Concussions can also occur from a blow to the body that causes the head and brain to move rapidly back and forth, literally causing the brain to bounce around or twist within the skull. This sudden movement of the brain causes stretching and tearing of brain cells, damaging the cells, and creating chemical changes inside the brain. Concussions have long been a mystery, and modern medicine still does not fully understand them or how to fully treat them. What we do know is that past practice has proven inappropriate and oftentimes way too aggressive. Back 15 or even 10 years ago, concussion management looked vastly different than it does today. Concussions were graded based on severity and duration of signs and symptoms, and there were typically three categories of gradation. The first, a mild or grade 1 concussion. If an athlete was identified as having suffered a concussion but the symptoms resolved within about 20 minutes, they were oftentimes allowed to return to play. This caused some problems as the instruments that were used to identify these concussions were not as sophisticated as they are today, and athletes could oftentimes talk their way back onto the field even though they were not actually ready to go. The second grade is a grade 2 or a moderate concussion. Athletes were typically held out for the game because the symptoms did not resolve within that 20-minute time span. Loss of consciousness may or may not have happened, but they were definitely not allowed to go back in and typically held out at least until the symptoms resolved the next day or days following. In grade 3, a severe concussion, athletes would be exhibiting mild, moderate, or severe symptoms that did not resolve for an extended period of time. There may or may not have been loss of consciousness, and they typically would be held out for a much greater period of time and handled more cautiously. However, there still was, and even to this day, are no truly standardized timetables for return to play. Depending on the physician, return to play protocols back then varied greatly. At times, physicians would release the athlete to play the day after symptoms resolved. Others would wait for days or even weeks until symptoms resolved. Some even incorporated gradual activity buildup, but this was not very often the case back then. Research being done on concussions back then began to demonstrate that the grading system being used was flawed. If an athlete suffered a concussion, regardless of severity, they should be removed from competition. Research also began to show that the negative impact of early return to play following brain injury, as well as research showed the long-term effects of concussion and the effects also of repeated concussions. Leading brain injury physicians from around the world first met in Vienna in 2001 in an attempt to enhance their understanding of concussions, guide future research, and standardize the evaluation and treatment of concussions. A total of 4 meetings have taken place since 2001, and as a result of these meetings, some consensus statements were written that provided guidance with today's protocols. The CDC currently has a 5-step return-to-play protocol that was derived from the 2008 meeting in Zurich. Beginning in 2009 with the Lysted Act in the state of Washington, states around the country have been enacting concussion laws to protect student athletes. In California, the first law was AB 25 in 2011, which mandated removing an athlete from competition if suspected from suffering a concussion, as well as providing for concussion education procedures. In 2014, a second law passed for the concussion protection, and it was AB 2127 by Assemblymember Cooley. This law established 2 primary practices in high school athletics, beginning in 2015. The first aspect of the law has to do with football practice. The law states that no more than 2 full contact practices can take place in a single week during preseason or the regular season. Full contact practices shall also be held to no longer than 90 minutes in duration. And finally, no full contact practices can take place during the off-season. The reason for this regulation in practice time is to reduce the number of exposures a player may have to contact, thus reducing the risk of suffering a concussion. Outside of football practice, AB 2127 also specifically addresses concussions. The law states, an athlete suspected of sustaining a concussion shall be immediately removed from the athletic activity for the remainder of the day. The athlete shall not be permitted to return to the athletic activity until he or she is evaluated by a licensed healthcare provider, and the athlete shall not be permitted to return to the athletic activity until he or she receives written clearance to return to the athletic activity from a licensed healthcare provider. The last major component of the bill states, if the licensed healthcare provider determines that the athlete sustained a concussion or a head injury, the athlete shall also complete a graduated return-to-play protocol of no less than 7 days in duration under the supervision of a licensed healthcare provider. Unlike other established return-to-play protocols, AB 2127 mandates a minimum number of days rather than a step-based protocol. There are a number of established return-to-play protocols being used in schools today, and the law does not mandate which one must be used. However, regardless of the protocol used, it may not be any less than 7 days in duration. Also, the physician must at least be aware of the return-to-play progress as defined by this law. As stated, the law does not mandate which return-to-play protocol to use following concussion. If your school's athletic trainer, team physician, or athletic healthcare provider are already comfortable with your return-to-play protocol, you may continue to do so as long as it meets the requirements of AB 2127. The State CIF Sports Medicine Advisory Committee has developed a recommended return-to-play protocol, which is posted on the State CIF website under the Sports Medicine then Concussion tabs. I will now discuss this form and protocol to help eliminate confusion with the process. First, let's review the instructions for this RTP. State law states that return to play, i.e. competition, cannot be sooner than 7 days after evaluation by a physician, MD or DO, who has made the diagnosis of concussion. Diagnosis could happen on the first day of the contest if the physician is present, but more likely it is the next day or perhaps the first day of the week. This graduated return-to-play protocol must be completed before you can return to full competition. A certified athletic trainer, physician, or identified concussion monitor must monitor your progression and initial stage after you successfully pass it. It is strongly recommended that progression be monitored by a certified athletic trainer or other highly qualified licensed healthcare provider. Regardless, someone at the school site must be identified as being the concussion monitor to monitor this RTP protocol. Stages 1 through 2D take a minimum of 6 days to complete. You must be back to normal academic activities before beginning Stage 2, unless otherwise instructed by your physician. You must complete one full practice without restrictions, in other words in Stage 3, before competing in your first game. After Stage 1, you cannot progress more than one stage per day, or longer if instructed by your physician. If symptoms return at any stage in the progression, immediately stop any physical activity and follow up with your school's athletic trainer, other identified concussion monitor, or your physician. In general, if you are symptom-free the next day, return to the previous stage where symptoms had not occurred. And finally, seek further medical attention if you cannot pass a stage after 3 attempts due to concussion symptoms, or if you feel uncomfortable at any time during the progression. In Phase 1 of the CIF State Return-to-Play Protocol, the athlete must have at least 2 full symptom-free days after having been diagnosed as having a concussion. During this time, there should be no physical activity which will allow for proper recovery and a full elimination of symptoms. The individual monitoring the return-to-play protocol should date and initial this form, thus recording the status of the return-to-play protocol for the athlete. This form is intended to allow for return-to-play progression documentation as well as guidance. Stage 2 of the CIF State Return-to-Play Protocol is divided up into 4 segments, each segment progressively increasing physical activity over the course of a minimum of 4 days. Once again, the date of completion of each stage should be noted along with the initials of the concussion monitor. All segments of Stage 2 should be supervised by the return-to-play monitor. However, Stage 2A in particular must be performed under the direct supervision of the return-to-play protocol monitor. Since this is the initiation of activity, the recovering athlete must be monitored closely for the possibility of symptom return. Each segment progressively allows for increased physical activity up to and including sport-specific non-contact drills. Prior to progressing to Stage 3, the physician must provide written return-to-play clearance for the athlete. The physician will have had the opportunity to be informed of the athlete's progress during the return-to-play protocol and be able to make an informed decision allowing the athlete to begin contact drills. This written clearance prior to Stage 3 will also satisfy the section of AB 2127 stating that the return-to-play protocol must be under the supervision of a licensed healthcare provider. With physician clearance, the athlete can now progress to contact practice. Again, this form was developed to allow for documentation of the dates that these phases take place. When the athlete begins Phase 3, assuming no complications, they will have entered the 7th day of the protocol outlined by AB 2127. Phase 3 requires that the athlete participate in at least one contact practice before returning to competition. If the athlete is in a contact sport, it is recommended that Phase 3 be divided into 2 days. The first day would include controlled contact drills, but no live scrimmage. The second day would allow for full contact practice, including live scrimmage. If symptoms do not return, the athlete may progress to Stage 4 and be allowed to participate in full competition. This return-to-play protocol form should be kept as supporting documentation with the athlete's athletic healthcare records at their home school. This concludes the review of the CIF Concussion Return-to-Play Protocol, which was established by the State CIF Sports Medicine Advisory Committee. Regardless of the return-to-play protocol used by the school, there are certain legal requirements that must be met as established in law by AB 2127. First, an athlete suspected of sustaining a concussion must be immediately removed from the activity for the remainder of the day. Second, the athlete must be evaluated by a licensed healthcare provider and must receive written clearance before returning to play. And third, if the athlete is diagnosed with a concussion, they must complete a return-to-play protocol of no less than 7 days in duration under the supervision of a licensed healthcare provider.